You're live. Cool.
All right, we're getting set up in here.
Yeah, refresh.
Oh, no. Oh,
There
there
it
we
is.
are. Yay!
Oh, wow.
Oh, I just got a notification.
Cool.
Cool. Features is
All right,
on
ladies,
there.
thank you for your patience. Before we get started, can you just let us know that you can hear us and see us okay? Hey, Ann.
Hey, ladies.
So here's like all the comments and stuff will be coming. All right, ladies, thank you for your patience. Before we get started, can you just let us know? Hi, Beatrice. Hey, Ann.
I'm just waving at everybody.
Ladies.
So here's like.
Can you read the comments?
Yeah.
See what
Yeah.
it says. I have a schedule.
Oh, we already got questions coming in. All right, so I'm going to give it like 30 more seconds. Just wait for, a few more women to join us. I know everybody's so excited to pick this man's brain over here.
Fire away.
Yeah. I asked him, I said, can we talk about this and this and this? He's like, ask me anything. So, hi, Deborah. Hi, Simone. Oh, there's Yvette. Awesome. So how we're going to do things, going to do like a little intro, introduce Dev, what he does, what he's good at, all that good stuff. And then I have a bunch of questions that I receive pretty much daily that are really common, involving like fat transfers and explanting and breast lifts, all sorts of breast lifts. Some other things I have written down here. So we'll go through the questions, and then at the end we will, or he will, answer those questions for you. Like if we talked about something and you need a little bit more clarity, or if you have another question, we will answer it towards the end, just so we don't get distracted and we can kind of stay on pace. But yeah, I think we should get started.
Yeah,
Ready?
let's do it. I'm
Cool.
ready.
So this is Dr. Dev. He works for Aqua Plastic Surgery in Jupiter, Florida. A lot of you may know Dr. Rankin, so he works in the same building as Dr. Rankin. This is their beautiful office here. But I want you to kind of introduce yourself, tell them like your schooling, your education.
Yeah. So I joined Dr. Rankin in Aqua Plastic Surgery 2 years ago. Interestingly, I've known Dr. Rankin since I was 18. My cousin and him are best friends, so when I moved here from India, my parents would not let me stay anywhere else but with my family. So I stayed with my cousin, and that's how I met Dr. Rankin. He had just started his surgery training, and I was a sophomore in undergrad, and so we've known each other on a personal level for a long time. And as I've gone through my training, we've kept in touch, and so I'll go in reverse chronological order. So I'm aquaplastic surgery, 2 years now. Before that, I was in Boston at Harvard and Mass General doing my fellowship in facial reconstruction and aesthetic surgery. Before that, I was at Temple University for 3 years for my plastic surgery training. Before that, I did general surgery and trauma, 5 years of training at that, close to Baltimore, and then med school. So it's been a long, fun road.
Yeah.
But I decided to come to Florida, wanted to join the practice with Dr. Rankin, who of course we're like brothers, and I have to maintain my tan somehow. So. Yeah.
We're better than Florida,
So that's kind of my training. With regards to the breast, I've had quite a interesting variety of training. In general surgery, we have the opportunity of doing all the mastectomies and the axillary lymph node dissection. So I did a lot of breast cancer removal surgery, and then on the flip side, when I went into plastics, we would do all the reconstruction. So I have a good feel for the breast anatomy when it comes to different types of pathology. And then I did get involved in explants in Philadelphia when I was doing my training there. So I've been doing explants since around 2012. As an independent surgeon, I've been doing them for the last 2 years in Florida. So I have a pretty wide variety of techniques and knowledge just about breast cancer, breast reconstruction, explant, the lymph nodes, and stuff that's related to our conversation today.
Yeah, absolutely. And just a little fun fact, when Dr. Dev did my explant, I had scar tissue wrapped around a lymph node, right?
Yeah.
Wrapped
Yeah,
around a
that's
lymph
pretty
node, and he was able to get in there and remove it and release it. I mean, how would you say it? Just
Yeah, your right side, I kind of remember this because we were taking videos of your surgery, and your nerve on the right side, the nerve that kind of supplies sensation to your nipple, and your skin was encased within your capsule. And then as they went up, I remember you told me you were having a lot of restrictions in that area, and so right in that axillary area where the implant goes up, there is a bulk of scar tissue. You talked about that lymph node that always gets inflamed, and so that whole thing was pretty much encasing that lymph node. So once you release the scar tissue, the lymph node basically opens up its drainage, and from what you've told me, that you've had really big improvements in your symptoms.
Yeah. So since 2014, and that was kind of the first indicator that something was wrong with my body. Since 2014, I've had a swollen, tender lymph node. And so for the last 4 years, every single month, I'm just dealing with the tenderness. Like sometimes it would hurt so much that like my sports bra, just even touching against it would just really hurt. I couldn't even lay on this side sometimes, but literally ever since my surgery, not one issue with that lymph node. Like
That's
not
great.
one issue.
Yeah.
That's crazy.
As the healing goes on, scar tissue does form. So Christina's been excellent following her post-operative regimen with massaging and stretching. So those techniques all are a huge advantage, so it doesn't return a year out after your surgery.
Okay, good. I don't want that little booger to come back.
Yeah, I know,
That thing
me
was
too.
so annoying.
And I know you have a video of it, so I don't know
Yeah.
if you've been able to share some of
I
that stuff.
haven't yet. It's
Okay.
on my to-do list, literally. It's on my to-do list
You
to
gotta
share that
edit it,
video.
Yeah, I
Yeah.
actually have it while I have it in a continuous format, so I think it would be great to now that we're talking about it,
Yeah.
to people actually to see what it's all about.
Okay. Yeah. Cool. All right. So I just kind of wanted to give a disclaimer before we get into like all the questions and everything. So I know a lot of you have already explanted and you have your, other surgeons. So, if Dr. Dev says like he recommends something, but your surgeon may recommend something different, always go with your surgeon, their advice, what they recommend, because they see you, they know your body, and so on and so forth. So, everything we're going to talk about today is how Dr. Dev does things, involving like drains and sutures and stuff like that. So again, just if you explanted with another surgeon, always just follow your surgeon's advice and do what they recommend. So all right, we're ready to get into some questions. The first thing a lot of ladies want to know about, the lifts.
Yeah.
So I know there's like horizontal lift, vertical, the wraparound tissue. So can you just let everybody know the different types of lifts?
Absolutely. So when it comes to lifts, a lot of the determination is how much breast tissue you have and how much skin you have and what the position of the nipple is. So from the most basic lift, which is called a crescent lift, so you can imagine the crescent of a moon, and so that goes on top of the nipple, so you get a lift of your nipple just by virtue of doing a crescent lift. So that's kind of the most basic one. One level below that is the complete donut lift or the Benelli lift. So if somebody's areola is enlarged and the nipple's lower, then you can make a circle around it and then lift all the tissue up just by doing a circle around the nipple. So if you can imagine it from an incision standpoint, one's just a semicircle above the nipple, that's the crescent. The donut is a full circle, and then you go down to the lollipop lift, which is an incision around the nipple and then going up and down, where you have to recruit more of that tissue from the side and lift it up. And then the biggest lift we do is the anchor lift or the inverted T lift, which you get the incision around the nipple, up and down, and then side to side. A in-betweener that we've been doing a lot is the horizontal lift, where you get an incision that goes underneath the breastfold, and you use that tissue that you have there and you kind of tuck it in. So when we talk about the tissue wraparound technique, that's something Dr. Rankin has improvised and worked on quite a bit. We do that mostly for the horizontal lifts and for the anchor or the inverted T lift, and that tissue is wrapped around and it's kind of secured to the underlying tissue with specific sutures. People always ask us what the advantage of the technique is. I think it's twofold. One is you can get more breast tissue underneath your nipple, and so that gives kind of the effect of an implant only in the lower portion of your breast. And then the second thing is it prevents your nipple and that breast tissue, especially if you're thin, from scarring to your chest wall and having that kind of significant scar. So that's something that it really does. So those are like the most common type of lifts that we do. I've been doing a lot of the horizontal lifts because as time goes on, gravity always wins with these implants, and so they drop and you get a lot of extra skin and tissue underneath there, so you sometimes don't even need to do a full lift in some of these patients.
Yeah, that's what I had. I had the horizontal lift and the wraparound.
Yeah.
So, yeah. Cool. Let me just see if there's any questions about that.
Mm-hmm. Kathleen.
Yeah, the prices do vary on the lifts. I don't know if you want to talk about that now, or if that's something maybe they should call the office for. I'll leave that up to you.
Yeah, I think you can call the office about the prices, but when you do a full lift, it's definitely more time, anesthesia, and materials involved, so the price goes up a little bit, but the variations aren't that much. So, sometimes we will charge you for a full lift, and if on table you're not the best candidate for it, and we do a little bit of a smaller lift than anticipated, then you pay a little bit of a less amount. So yeah.
Cool.
So there is variation in the prices.
Yeah. Okay. Let me just read this. I had nipple and skin sparing mastectomy done in 2013 and was reconstructed using implants. I'm now sick with breast implantitis and looking to explant. Is it better to wait for explant to heal before doing a fat transfer, or will the skin just fold in on itself and have to be fixed when fat transfer is done?
Yeah. So with skin sparing mastectomies and nipple sparing mastectomies, it's really tough to do an explant and a fat transfer. The fat that we inject, it typically goes into breast tissue, and so you get volume within your breast tissue. So when you've had a mastectomy, you don't have any breast tissue. It's only your skin and a small layer of tissue on top of there. So, we've been doing, what you can consider doing, and it depends on the size of your breast, is sometimes you can do muscle flaps, and you can take some muscle and skin from your back and fill the volume of your chest with that flap, and then you inject fat into that and you get a breast mount. It's definitely a lot more surgery, but I don't think injecting fat directly into just an explant, especially after a mastectomy, you're not going to have any fat survival in those situations.
Oh, wow.
Yeah, those are tough situations. So I have explanted quite a few mastectomy patients. Most of them are older, so they don't really desire to have a breast mount. They just want to get rid of some of the pain or the symptoms they have from breast implant illness, and they're fine. They get an external prosthesis placed. Actually, the youngest one I've done has been in her 30s, and she's pretty happy. But fat transfer, for my research and for my protocol, I never do a fat transfer after explant directly, whether it be from a mastectomy or for a cosmetic breast augmentation, because I like the tissue to heal and settle, especially after doing an en bloc capsulectomy. And then as the breast settles, most of you who has explanted know that the tissue continues to mold over time.
Right.
And at the earliest I've done a fat transfer is 3 months. I think 1 year is kind of a typical time frame.
Okay. That's a good transition, because now we're going to talk about fat transfers, because I get a lot of questions about that. So you kind of answered one of the questions, which was how long after an explant should you or can you, or is it safe to get fat transfer? So 3 months is like the earliest.
Yeah, 3 months is the
like
earliest.
A year.
Yeah, in my mind, and just from reading, I kind of reviewed 15 to 20 papers, and I picked 5 of them that I thought had some really good data. In my mind, when you do an explant and you're insulting the breast tissue that's already there, injecting fat into tissue that's already kind of struggling doesn't make sense to me. So I think the fat survival rates are lower. And then the second thing is, I find it difficult to assess where exactly to inject the fat cosmetically, because that tissue is going to change and mold over time. So waiting 3 months allows for that swelling to go down. It shows you where the breast goes, and then you can put it wherever you want and get the kind of aesthetic goal that you have. And sometimes patients need 2 rounds of fat grafting. They'll do 1 round. You don't want to inject too much fat into their breast, because it overloads it and that fat won't survive. So some patients need 2 rounds of fat grafting.
Okay. Yeah. Cool. And so with the qualifications to get that, like
Yeah.
You know, how much fat do you need? Where do you take it from?
Yeah, the most common areas are the abdomen, flanks, back, arms, inner thighs, sometimes the outer thighs. And then to be a good candidate for fat transfer, you have to have some breast tissue to inject the fat into. Theoretically, you can inject it into the muscle, but I don't think you're going to get that. The muscle can only expand so much. And so to get a good breast mount, I think you need some good breast tissue to inject it to.
Okay. Anything else you want to say about fat transfers?
No, I think it's a great option. You know, when people ask about sizes and how much fat to inject, you can almost imagine. So say if you had a 350cc implant explanted, and so the implant, you know, its goal is to sit high and give that upper pole cleavage. Fat doesn't do that. Fat sits more naturally with gravity and it falls. And when you inject, say, 350 cc's of fat, that you can say is almost equivalent to putting a 350 cc implant in, you're going to lose about 30% of that fat. Your body will reabsorb it. So, so you typically overcorrect the amount you inject in order to achieve a size that you can have in. With fat, you know, I typically say you'll go up to half a cup size to a full cup size with fat injected. It's almost impossible to go from an A cup to a D cup with fat.
Right.
I think that's unrealistic.
So when you do the fat transfer, do you tend to put more than what you typically think you might need in there because you know that some of it's going to go away?
Yep, yeah,
Okay.
It looks really swollen. Patients are kind of like, what did you do?
Yeah.
And then, you know, you reinforce, show pictures and kind of talk them through it. And then by the time it's 3 months, you know, everything's settled so nicely.
Yeah.
And then you do massaging and it's just a natural soft look. So
Cool. And I know, Cecilia, you asked what I had done. So I had the horizontal lift and the wraparound tissue. Is that considered a full lift? I know somebody just asked that. A horizontal and wraparound?
Horizontal wraparound, it's not a full lift would be around the nipple, up and down, and then a horizontal incision. So that's what a full lift would be.
Yeah. Okay. Is it okay to have an explant and lift at the same time? Yes.
Yeah.
Most women that need it or opt for it do it at the same time. Yeah.
Kelly's asking, do you have to go under for fat transfer? Yeah, I like to do it under anesthesia. There's a lot of position changes. So, you know, you're laying on your belly, you're laying on your side. So for maximum comfort, you definitely have to go under for
So
it.
is it basically lipo and the fat transfer all in one surgery? You take the fat in one shot and then you
So and one big advantage of it is that you get really good body contouring with the lipo. So I like to sculpt and do some etching and different type of things that help for contouring. So I think it's you get two things out of it.
Yeah. Should I go off HRT before explant surgery? You know what HRT
Yeah,
is?
it depends on what you're taking it for. You know, sometimes patients on HRT have a higher risk of blood clots depending on their medical history. So I think I'd have to go into more detail about your HRT and talk to even sometimes your primary care doctor or your endocrinologist who's put you on HRT to decide if you need to stay off of it.
Yeah. Thoughts on doing full torso lipo at the same time as explant and lift, as long as there are not major complications. If not, full torso, upper back, and bra areas.
I mean,
Is that a lot?
No, you can do it as long as you know that you're not going to need that fat for a future fat transfer. You know, we call fat liquid gold. So once it's gone, you know, it's never the same fat. Usually, if you lipo and then you do an explant lift, and then 6 months later you come back and say, "Oh my God, I wish I need some fat in my breast," and the quality of the fat is a little bit different. So if you are fairly confident that you don't want to do any fat transfers down the road, then yeah, it's fine to do. I mean, we've combined different procedures with explants and lifts. For example, I've done revision rhinoplasties, done some tummy tucks, so liposuction.
Yeah. All during the next plan as well. Is that what you're saying?
Yeah.
Oh wow.
Yeah, because the procedure is about, you know, depending on the lift and the volume, it can last from 2 to 3.5 hours, and then you can bundle it with another 2-3 hour procedure. It's okay.
Yeah. There you go. Very cool. Cool. I think we. If I missed your question, just ask me again. I do apologize because I do have some coming through, so I may have missed yours. But yeah, just ask me again, and we'll definitely. I want to address all your questions and everything while we have him here. So then let's kind of get into like BII and explanting and symptoms.
Yeah.
So from the surgical side of everything, when a woman comes and says she wants to explant and she hasn't been feeling good, what are the common symptoms that she complains of having?
Yeah. Most common, I would say top 5. One is brain fog, fatigue, joint pain, rashes, hair loss. I've been seeing a lot of Hashimoto's and thyroid issues. That's been a big one. Rheumatoid type issues, and then ear ringing in the ears. I think some of the gimmies that are, kind of this musculoskeletal type symptoms by virtue of the weight of the implants, or if they're contracted, so they have pain in their shoulders, neck, sometimes in the sides over here. And then just kind of skin rashes. Those are some of the most common ones.
Yeah.
So I guess more than 5.
Yeah. Yeah. Crazy. And then, so like after you do somebody's explant, like let's say they had a lot of those or all of those symptoms, and you do their explant and then they come back 6 months later, do you find that most, if not all of them, like their symptoms improved or have gone away?
Yeah. I would say, and this is all anecdotal, when I did my research on this stuff in Temple, everyone would say 50% of the symptoms improve, 50% don't. I think from our practice and, speaking with Dr. Rankin, we have an overall improvement in like 75 to 80% of the symptoms. One that is a gimme that goes away, most patients will say, oh my god, I can breathe better. And that's just by virtue of not having that weight on your chest. I mean, everyone wakes up and they typically say that. And then the brain fog and the fatigue are usually quick to resolve. I didn't mention allergies and inflammation of the gut. Patients have started reintroducing their original diet they had before they had implants placed. So it varies. I mean, everyone's different. Patients send me pictures of their hands and their rashes are gone after a week. Some of them have them stay for months. It's so variable. It's tough to say who's gonna get better when, but as long as everything's taken out, then rest be assured that you're really ill from the implants and you're gonna get better.
I agree. What is the difference between and why docs use MDs versus CRNAs?
Yeah, so CRNAs are certified registered nurse anesthetists. It's kind of I think more of a political thing. An MD is a doctor who's gone through anesthesia residency training. A CRNA is typically a nurse who has done trauma, ICU, nursing, and then has done formal training to be an anesthetist under the directorship of an anesthesiologist. So when you go to a hospital and get surgery done, there's always an anesthesiologist who oversees the CRNA. For outpatient surgery centers, you are, as long as you have a fully certified operating room and a medical director like myself or Dr. Rankin, who are trained in all the kind of ACLS, advanced cardiac life support protocols, basic science, basic life support protocols, you can have a CRNA doing your anesthesia. I have worked in both situations, and we have Malone with us right now, who is 17 years. He's pretty well seasoned, and he's definitely catered to our breast implant population as far as narcotics minimization, and he's come up with these really nice protocols. So as long as you have an involved anesthesia provider, it's fine. I would have my family members operate. I would operate on them here under our facility, even with the CRNA, without any hesitation. I've had my cousins and some of my best friends, I've operated on them here and have no issues with them. So
have you had a PT with chest pain that radiated to left auxiliary and resulting from implants? I have been checked out and they didn't find anything wrong with me. It was accompanied by shortness of breath. I am young and healthy. None of it makes sense.
Yeah, that's definitely radiation adds another dimension to pain, and especially if you've had radiation to your left axillary region. I kind of need to have a little bit more detail about your surgery was, when it was done, the type of radiation, your tissue pathology. I think that's kind of a little bit more of an in-depth, detailed consult to discuss that. I wouldn't try and presume different diagnoses unless I'm able to know a little bit more about that situation. But because radiation just adds a whole other level of complexity to the situation. Have I treated patients with radiation? Absolutely. But again, I usually spend an hour with them looking through their records before we come up with plans and ideas.
And then as far as insurance goes and codes, is that something they would talk to Lauren about, or?
Yeah, you know, because BII doesn't have a recognizable ICD 9 or 10 diagnosis code, so insurance companies don't recognize it. If you have capsular contracture, like grades 3 and 4, then you might be a candidate to consider it. But for the most part, we don't have an insurance code for it. Obviously, if you had a mastectomy or breast cancer, then it's a different situation.
Right. Yeah. And then I saw something about Nerve Bloc. I thought, do you use Nerve Bloc when you do explants?
Yeah, everyone gets a Nerve Bloc. The different type of Nerve Blocks are, we use Exparel, which is a 72-hour Nerve Bloc. It's an added cost because we have to pay for the medication. And then otherwise I just do a regular Nerve Bloc with Marcaine, which lasts about 12 hours. And so I do targeted intercostal Nerve Block, so I block 4 ribs, and that provides some relief afterwards.
Yeah.
About 12 hours.
I think it's well worth the money. I didn't want to take any chances personally, and I was like, I
think it's
gladly
great.
do it.
Yeah, well, if you do a good nerve block, you're going to be blocked for 3 days, and so it minimizes your narcotic use. You're not nauseous, and you know, you feel more like you're kind of able to do things. I mean, my only hesitation with it is you sometimes feel so good that you don't realize that you're doing more than you should.
Right. Yeah. Yeah. I didn't take one prescription medicine. I just took extra strength Tylenol for like 2 days, and I was good. I didn't need it any time after that. So I personally feel like it's well worth the money. A couple more questions were, how long typically is the recovery after a lift? I mean, I'm sure it depends patient by patient, you know.
Yeah, for most of these, it's pretty cut and dry. We always say the recovery after any surgery and the explant or lift is 4 to 6 weeks. At 4 weeks, depending on your swelling, whether your incisions are completely closed up, you know, I introduce you to start light activities, so anything lower body related is fine. And then at 6 weeks, then you can start doing your regular workouts and just kind of gradually build it up. The reason why we wait for so long is because as you're healing, if you do any kind of activities with your blood pressure and your heart rate going up, you get more swelling and you can get fluid collections, and you don't have your drains in as an insurance policy to collect that, then you can get problems from that. So
okay.
So more fluid, more swelling, more pain, more scar tissue, compromised result.
Yeah. And then recommendations on scar treatment?
Yeah, I'm old school when it comes to that. I just like massaging. You know, moisturizer of your choice, vitamin E, any oil that you like, and you just have to massage them 2 or 3 times a day, religiously for up to a year. I don't see any point in, people always ask me about Mederma. We're taking out silicone, so it totally negates the whole healing process by putting silicone on it for scar treatment. So I always advocate against doing that, and then from my standpoint, massaging is kind of the way to go, and I saw that early. Dr. Rankin likes to do taping, that's his kind of protocol, but from my standpoint, I like to wash the incisions every day with soap and water, clean it, and then massage it, so you're looking at it every day.
Yeah, I think, so I think I took my tape off after like 6 or 7 days and just let it air out, just using coconut oil on it. And I think Rankin, correct me if I'm wrong, but I think Rankin likes to have it on for like 3 weeks, but you change the tape like every 2 to 3 days.
Right.
For those 3 weeks.
Right.
So, you know, every surgeon has their own protocols and how they like to do things.
Yeah,
so.
the theory behind it is very similar in that there's a pressure on the incision, and so when you massage, you're putting pressure. When you're putting tapes, you're putting pressure on it. The difference in my mind is that the tape has adhesive on it, and so you can get a reaction from it. And then the other thing is I like that the incisions are washed on a frequent basis and clean. So
yeah, Cool. We got to that one. Did all these. Somebody asked, do you do implants as well? He does.
Yes,
Do
yeah,
implants?
we do.
Mhm.
You know, somebody asked me today if I do butt implants. That's a big no. I've never done a butt implant.
So if you see that information out there that Dr. Dev did a butt implant, it's not true.
It's not true. I do butt lifts, as in Brazilian butt lifts, which is the fat injections to the buttocks. But you know, as we are learning more about breast implant illness, I have been educating my patients about this illness that we've recognized along with the symptoms. So if anyone comes in for a consultation for breast implants, I do talk to them about breast implant illness. I don't have any concrete numbers, so I give numbers from my own practice, and I kind of tell them that, you know, I've had patients who are 3 months out from surgery, complain of symptoms,
Oh, wow.
30 years out from surgery, but we also have patients out there who do have breast implants and are not suffering from the implants. So
Right.
I think the key thing is now just recognizing that we know what the symptoms are, we recognize them, and so we're able to kind of advocate, saying, okay, you have implants, you have these symptoms, what are the chances that these, and you had a thorough workup like you did.
Yeah.
You know, so taking them out is kind of the diagnosis and treatment. So, but yeah, I do breast implants.
Wow, somebody had a reaction to Moderna. There's
Why
silicone.
that did, yeah.
I'm under the muscle and have osteoporosis. I'm holding off on my, do you know what this is? Prolia shot? Because I'm afraid of capsule on ribs. Do you cauterize if you can't get all the capsule?
Yeah, typically you can get all the capsule off the ribs if I think you're in a good plane. Yeah, there's definitely some patients who are really scarred down and you take a little bit longer to take it off. If there's an inadvertent tear in the capsule while you're doing it, then I do two things. We have a little scratch pad, so I scratch the surface of it to get a healthy bleeding tissue, and then I cauterize it, so it's kind of a twofold treatment. And we used to do that for our breast cancer patients, so that's how I learned about that.
Yeah.
Yeah.
What is MFTHR, and is the test necessary?
I don't think it's necessary. I think, you know, you can leave that the genetic test up to either your rheumatologist. I personally don't advocate it to every patient. You know, if that's gonna change down the road, maybe. But yeah, if you do have an MTHFR, we do alter our anesthesia a little bit, and I've been giving all the MTHFR patients a dose of blood thinners prior to surgery because they're at higher risk of developing blood clots. So I give them a subcutaneous shot of heparin, and then frequent walking. If you've had a history of blood clots and you're MTHFR positive, it changes the treatment a little bit, so you might need to be on blood thinners for longer after surgery. So that's something to definitely discuss with your surgeon. If the surgeon is not aware of the MTHFR profile and how the treatment is, and definitely get your hematologist or your rheumatologist involved so you can come up with a guided treatment plan for your post-op care.
Yeah, wow, that's cool. Do you often run into transdermal mesh that sometimes is put inside after reconstruction surgery and doing your explants? If so, is there a different technique?
No, the technique ends up being very similar. So the reconstruction mesh I run into is for the breast cancer patients, and so I always review their op notes to see what kind of mesh they've put in, what plane it's been put in, and so and then the capsule does incorporate with the mesh, so you have to take the mesh out most of the time and do a little bit of muscle repair and reconstruction. So it's a little different level of complexity on how to repair that and take everything out. So I just did, I mentioned previously the 70-year-old patient that was contracted. So she had mesh in, so I had to take out capsule, mesh, and then do a muscle repair on her.
How many months after the surgery I get a mammogram? Or how many months after her explant can she get a mammogram?
Yeah.
Oh, right.
Yeah, so mammogram, so I think the goal is to get a mammogram before the surgery, and then that way you have a basic framework of your architecture of your breast prior to doing anything to it. So if you're booked for surgery, say in December, get your mammogram done before that in November sometime, and then your next recommended mammogram would typically be in 6 months to a year. So if you get a mammogram 3 months after surgery, they're gonna see a lot of scar tissue, and then there's the information is basically doesn't have any value because they'll see calcification, scar tissue, and then they'll start thinking about, oh, should we biopsy something, or they'll send you for more tests like an ultrasound and an MRI, and you just kind of fall into this cycle of more testing. So get your MRI done, or get your mammogram done before, so you have a basic framework.
Man,
thanks, Lynn.
going
Kelly.
over so much today.
Yeah, it's a lot of
It's
stuff.
awesome.
Yeah.
My doctor didn't recommend a mammogram prior to surgery. I just wanted to say hi, Lynn Kelly.
What's up, Lynn?
Day 4
Glad
post-op.
you're doing well.
Awesome. What dictates? This is a good one. What dictates pathology or testing being done? Is there any way to see the ALCL during surgery?
Yeah, so
Good
for
question.
pathology, now if you have textured implants, we're sending all of them for pathology because the BIA-ALCL has been linked to textured implants. So if we're in there and we find any form of textured implants, automatically the capsule, or if there's any fluid in there, it goes for culture and pathology. If there's any abnormalities like abnormal calcifications, abnormal thickening, something doesn't look or feel right, we are erring on the side of caution and sending it for pathology. Some patients do ask automatically to send it, and we're happy to do that. But most of the pathology that we've gotten back has been just kind of foreign body, capsule, kind of typical stuff they would see. I've done some lymph node removals, and they've come back with silicone granulomas. And then culture-wise, I personally haven't had any mold or any kind of awkward bacteria come back. I have seen other surgeons who have seen mold, but you can see mold. I mean, mold is mold. It's gonna be, looks like this black cauliflower. So textured implants definitely get pathology through a BIA-ALCL. Otherwise, it's typically at our discretion.
Yeah. So lots of controversy around when to perform en bloc versus full capsulectomy.
Yeah, I think it's a good question, Violet. En bloc pretty much means that when you're taking out the implant and the capsule, everything comes out in one piece together. When you talk about full capsulectomy, you can take out the implant and do a capsulectomy, and take out the capsule and the implant separately. So that's what a full capsulectomy is. So you're taking out the capsule, but you're making a cut in it, and you're basically pulling the implant out, putting it on the side, and then you're taking the capsule out separately.
Oh, okay.
So when it's en bloc, just think of the whole thing coming out in one piece. They get the term en bloc from cancer resection. So when we were doing like abdominal cancers, you want to take out the cancer en bloc, so you remove everything around it, including some of the healthy tissue. So that's what en bloc is. And so the theory is that if you cut open the capsule and you have a ruptured implant, you're going to have silicone leaking into your breast cavity. So that's the difference between a full capsulectomy and en bloc. In our practice, we are striving to do every case as an en bloc, so we have consistent results as well as a consistent technique that's reproducible.
Yeah. Do you get an extra bill from pathology if you end up sending anything?
Yeah, I'm gonna have to direct that question to my office. We do. I think some of the patients will get a bill if they don't have insurance, or their insurance is not gonna cover it. I think if you have textured implants, because of the recommendations to send it, they might cover it. But if you don't, then I think you might get a bill for it.
And then, do you think it's a must to get en bloc if you have silicone implants?
Why, the theory is not just for the silicone implants, the saline implants as well, because it's the capsule that's stimulating that foreign body reaction. You can imagine that the silicone and saline is protected by the breast implant shell, so most of the illnesses is presumed to be coming from the capsule, not from the capsule, but the shell of the implant. So whether it's saline or silicone, I think it's imperative to attempt to do an en bloc.
And then, is muscle repair necessary for all under muscle explants? No, I didn't have any muscle repair at all, and my implants are under my muscle.
Yeah.
So it just really depends.
Yeah.
I'm sure from.
Yeah, it depends on where your muscle is, you know, how much your muscle has ridden up. The normal anatomic position of your muscle, you know, you want to see it come down to the bottom of your nipple level. So when you take the implant out and you just fold the tissue down, if your muscle falls within that range, there's no benefit of doing a muscle repair. Now, if your muscle has ridden or contracted high, then you can release the muscle, bring it down to a more anatomic position, and suture it to your breast tissue. Some people ask, oh my God, why don't you suture it back to my chest wall and put it back? It's just going to tear out once you act. It's such a powerful muscle. Once you activate or you even lift your arm up, all the sutures are going to tear out. So, yeah.
Wow. Yeah. My doctor talked about a new technique of putting a fluid inside when removing the capsule that would kill any bacteria.
Yeah.
Have you heard of that?
Yeah, there's different things. I mean, that's also an area of open discussion. So, you know, we use triple antibiotics, which pretty much target everything. And so you're getting rid of contamination. There's other things that you can put in there to kill bacteria. Personally, I don't think you can put betadine, triple antibiotic. There's another compound you can put in, but as long as you are cleaning out the entire breast cavity with some form of a liquid, I think you're fine. And then the key after that is, in my opinion, is drainage. You know, all that fluid that's building up there is a nidus for infection and swelling. So I always put drains in so that you can get rid of all that stuff.
All right, we've caught up to the questions on there. Great questions.
Yeah, you guys are
Wow,
a tough
we're covering
crowd.
so much. Gosh, I'm like learning over here. So, do you believe in breast implant illness? You know, like what is your take, opinion, perspective, all that stuff?
Yeah, I think we touched on about that a little bit. I do believe that there is a population of patients that are suffering from some kind of reaction to the foreign body, you know, and it's well elucidated in some of the symptoms. So I've learned about it from listening to patients like you who are great advocates and the patients that I've treated. And the fact that patients are getting better afterwards, you know, just with energy and just everything. I mean, just looking at, your skin and your hair and the whole overall well-being, talking to your husband, and you know, that's, you know, when your significant other, your spouse, can attest to the fact that you've had these implants taken on you've gotten your wife back. I think it's a big testament to that there's actually some reality behind it. So I do believe in it. I don't think everyone gets it. I know there are plenty of women out there who are walking around and have implants and don't have it. So we touched on why I still do breast implants. I think until more research and studies are done and there's an exact science behind it, I can say I can kind of swerve in one direction. But for me right now, it's recognizing the symptoms, listening to my patients, doing a thorough surgery to encompass some of the most important steps for you to get better, and then cosmetically trying to achieve the best result we can.
Yeah. I think we already touched about the chest muscle with the reconstructive. That's a good one. And then this one's about drains. Typically how long?
Yeah, I leave them in for a week. Some people try and do 3 days. My big theory behind that is you do the nerve block, you have your drains in, you're gonna feel great. Then at day 3 or 4, once that medication wears off, you're gonna be in pain, you're gonna have some swelling and fluid buildup. So the drains, the biggest thing about the drains is one, okay, they can maybe be a nidus for infection, but typically we leave drains in for 7 to 14 days. It's not an issue, and then they're just a pain in the butt to deal with. And I've never had drains, but I've listened to you and all my other patients try and con me into taking it out. But I like a week. Just it's an insurance. It's a good insurance policy. The last thing you want, and does this happen every no? But when you get a fluid collection in there and you have to come back to my office every week to stick a needle in to drain it out, it's not fun for anyone. So.
After somebody had their explant surgery, about how long should they stay close to home before like traveling?
Yeah,
especially driving themselves and stuff like that. What would you say?
Flying airplane.
Flying an airplane, whatever it may be.
fly right out of Aqua. For driving and stuff like that,
Yeah,
as
like
long as you're off
getting away.
pain medicine and you're comfortable a week after surgery, after your drains are out, I think that's fine. I always say do a local drive within your neighborhood to see what your reaction times are, because you're always sore where the muscles are. So as long as you can kind of maneuver your body side to side and avoid those blind spots, you're able to see where the blind spots are, and you're okay to drive.
Yeah, I think I waited a solid 2 weeks to drive, and it's mostly the turns that, were the hardest, was turning. So that was just me. And then Lori asked earlier, so the mammogram shows that one silicone implant is much smaller. So what happens if it's ruptured, and can you tell if silicone has leaked inside of her body? Like when you go in and do the explant, are you able to actually see that? And like what do you do at that point when you realize that somebody has a ruptured implant?
So if the rupture is contained within the capsule, then it's great because you do an en bloc and you remove it all out. If the rupture is outside of the capsule, then you have to do a lot of cleaning. And then it comes down to checking the lymph nodes and the surrounding breast tissue. I actually did a case on a breast cancer patient who had silicone in all of her reconstructed tissue from a ruptured implant and in her armpit. So you just, the mammogram won't tell you the information you need. I would then get an MRI. And the MRIs are actually surprising, and ultrasounds are great at telling you where exactly all the silicone is, and you can kind of create a roadmap and go after all the silicone that's in there.
Yeah. Do you see ruptures a lot? I'll never forget Susan McPherson's video. I mean, I feel like it went viral on the internet, but Dr. Deb opened this implant and it was just yellow goo inside the capsule.
And there's,
and she didn't know it was leaking, right? Like she didn't realize it was like that.
No.
It's crazy.
Those, I see quite a few ruptures, and it's gratifying to take them out because once you hit that capsule interface, you can tell when it's a rupture. It has a different consistency, so it slows down your surgery a little bit because you're just super meticulous not to cause a single tear or any kind of contamination. But I do see a fair amount of ruptures.
And then you had somebody ask where Dr. Dev is located?
Yeah.
So he is in you have a couple locations, right?
Yeah,
Few locations.
Jupiter is our main location, and then Fort Lauderdale and Miami as well.
Yeah, and he has a bunch of openings for Fort Lauderdale and Miami, November and December. So, if you like, everything he said and you want to consult with him, definitely has some availability for November and December.
Come chat.
In Fort Lauderdale and Miami. I think you're booked out to the end of December, early January for Jupiter?
For Jupiter, yeah.
And
then for Miami, we have openings starting November, actually.
Cool. Yeah. And we'll give you the phone number and everything. Just give them the phone number now for the Jupiter one.
Jupiter is 561-776-2830. And then Miami, 305 918 1750.
Beatrice, you come over here and say hi since you're here, and this is like a perfect segue.
Yeah.
So Beatrice, you're the office manager for the Fort Lauderdale and Miami offices,
yes,
right?
Yes, I am.
Yeah. So this is who you'd be talking to, setting up your consult.
Give me a call. I'm happy to help you. My cell phone, you can call me directly at 561-385-5135. I'll talk to you ladies soon.
Yeah.
Cool.
Good people over here.
Yeah.
Great team. Good energy. All right. And then, so I think we addressed like a lot. It's been almost an hour, so if you've been sticking around with us for an hour, man, we appreciate it. It's awesome.
Yeah.
So let's do like that rapid fire question thing that I talked about. So for those ladies who are explanting really soon or have already explanted maybe within the last day or two, I know you have a lot of questions about like when can you do that or when is it safe to do this. So I just wrote down quite a few of the most common questions that I get about post-op care. So when can you lift things like your baby? I know it's a common one.
Yeah, you should have your husband lift your baby for the next year or two.
There you go.
It depends on how heavy your baby is. Typical weight restriction is for up to 4 weeks, nothing greater than 10 to 15 pounds. And then if you're healing well and your swelling's down, then between 4 and 6 weeks, like 15 to 20 pounds. And then after 6 weeks, you can lift whatever you want. So if the baby's heavy, I always say when the drains are out, then you can have the baby come and sit on your lap, and then you can kind of girdle him and lift him or her up. But don't anything that's kind of using your arms to lift the baby up that's heavier is a big no-no.
Yeah. And then driving, give or take. How long can they drive themselves?
I think 7 to 10 days, but you.
And this all depends woman to woman and
Yeah.
case to case. So
Yeah.
it's just ballpark. What about wash your hair by yourself, lifting your arms up?
Yeah. I'm okay with that, as long as we talk about the T-Rex position in the beginning, but I think after your tapes and then drains come out, like after a week, you can start doing more upper arm stuff. Because personally, like not washing your hair or showering, it probably is one of the best feelings when you do it.
Yes. Sleep on your side.
Yeah, that I've been doing kind of very patient directed. If the swelling is down, your incisions have healed, you can sleep on your side anywhere from 2 to 4 weeks with a pillow and some support, like not on your full side, but kind of leaning towards your side.
Yeah. I think drains we went over, anywhere from 1 week to some women I've seen have them like 18 days.
Yeah, my longest was the one was ruptured and then the quadruple implant patient. I left those in for about 2 weeks.
Lift weights, like exercising, lifting weights.
Yeah, light stuff at 4 weeks, and then 6 weeks, jump into it.
And then take a bath.
I'm 48 hours. Yeah, are you talking about shower or
like a bath, like soaking in a bath.
Soaking in a bath.
Taking a nice hot bubble bath.
If your incisions are healed up, 2 weeks is cool.
2 weeks.
Yeah.
Cool. And then arms above the head. I know I couldn't really lift anything above the head or pull anything down.
Yeah.
For what, like?
Yeah. For that, and again, it's kind of.
Does it depend on the lift or not?
The lift doesn't do it. I think a lot of it is on your scar tissue and how much, if you have a muscle repair done or not. So that's another 2 to 4 weeker.
Cool. And then any other questions that I may have missed about like post-op care? How long before riding on the back of a Harley? Oh, okay.
Nice.
Oh, I know where that is.
Yeah. Probably around 2 weeks before you would consider. The biggest thing is if it's bumpy and
those bumps.
Yeah, if things are shaking,
different.
it's uncomfortable. So I would say 2 to 4 weeks for that as well.
Yeah. We talked about the bath, and the hot tub's going to be different because they have chemicals in them. Like, would you say later than 2 to 4 weeks for a hot tub as opposed to a bath, or is it about the same?
I think it's okay because once the incisions are closed up, unless you have a little opening on your incision, I would use the same time frame for that. I think somebody had a question about a lymph node.
Did they? Do you have that question?
Yeah, she says, do you remove / test any affected lymph nodes at surgery time?
Yeah, I've done. The advantage of having done general surgery is I know the levels of the axillary lymph nodes, so I check all the lymph nodes on every explant patient. I don't know if you've seen any videos, but it'll show you. I'll have my one hand in the chest cavity and the other, and I'll be feeling the lymph nodes, and I'll look inside. If there is something untoward towards the lymph node, then I'll take it out and send it for pathology.
Yeah.
For sure.
Yeah, and thanks for asking that, because that was actually on here for me to ask him, which was, can you describe the auxiliary scar tissue and the ability to release it and examine the lymph nodes? So, yeah.
And then Yvette had a question too, just to follow up on the unblock conversation, which I think is important. She asks to please explain when unblock is not possible. There's lots of incorrect info out there.
When you're not able to do it?
Yeah. I think if you have, the big thing about unblock is you have to be able to take out, say if you have a 600cc implant, you have to have a big enough incision to take it out unblock.
Right.
So in theory, unblocks should be achievable every time. Obviously, the other thing that prohibits is the amount of scar tissue, and especially if it's under the muscle. I mean, some of these, if it's calcified almost to the ribs, then you take out as much as you can, and you sometimes have to use specific techniques to even take some portion of the rib out, so that wouldn't be a true en bloc in those situations. And then you do like the scraping and the cautery and stuff like that to get everything out. So as long as you have healthy bleeding tissue on the ribs afterwards, then you know that you've taken out everything. And wash everything out, check, recheck. Sometimes I check 3 or 4 times before I do a closure to make sure everything's out.
Yeah, they're very thorough and meticulous here at Aqua. Yeah, you're gonna get like the best of the best here. Natural antibiotics option. So like, are you asking like for like colloidal silver or oil of oregano, stuff like that? Like, how do you feel about antibiotics? You think it's absolutely necessary just to not take any risks, or?
Yeah, the studies show that when you take an IV antibiotic 30 minutes before you make a cut, it reduces your incidence of surgical site infection dramatically, and that's actually part of our protocol in the hospital, that you have to get it 30 minutes prior to incision, so you have circulating levels of that antibiotic. And then afterwards we do it because we have drains in, and so again, that's the studies on that aren't concrete, but in my mind, if you have a foreign body in there, it's best that you have some antibiotics to help prevent infections. If you're sick from the antibiotics or it doesn't react well to you, then we can kind of individualize your antibiotic therapy, but for the most part, everyone gets it.
And then, can old capsules be attached to the ribs if it was done under the muscle? Old capsules.
If you've had your implants taken out and they took maybe just the top portion of the capsule out, sure, you can have an old capsule attached to the rib. I've seen it. That's definitely a possibility.
Now that same person asked earlier, would there be capsules after 30 years period, I think. And then she had another question.
I'm pretty sure.
I don't know if you guys covered that. Can you see?
I think it's Pern, and I'm sorry if I messed up your name.
Yeah, Pern.
But I think her and I talked earlier, and I think, and if this is wrong, just let me know, but I think she had implants before. She got her implants taken out. She got a new set in. So I think she is afraid she might have 4 capsules now.
No, once you form a capsule and you put a new implant in, your body doesn't reform a capsule around the implant unless they put it. So say if you were above the muscle before, they took out the implant and then they put a new one under the muscle, then you'll form a capsule in that area. So then you'll have that old capsule above the muscle that wasn't taken out, and then you'll have the new capsule form. But if you've taken out your implants 10 times and replaced it with other implants, the capsule is the same unless they've done some capsular work. So and those capsules, they'll stick to each other, and the key is to, when you take out the implant en bloc, you're gonna see healthy muscle, healthy breast tissue, and healthy ribs. So you identify that healthy tissue that you have in there.
All right. It's been an hour.
That's it.
Cool. So let's just get ready to wrap it up. I mean, definitely, if anybody has a question or two, feel free to ask. But yeah, we definitely covered a lot.
Yeah, it was a good session. I don't know if you wanna talk a little and tell what your experience is, because I think Christina really touched on a really important thing about spouse support and having your significant other understand what it is to explant, and that support's important. And I've seen both kind of spectrums, and when you're on the other end of the spectrum, you don't have that support. I think it's a really tough situation. So I'll let you introduce your husband. And
Hey everybody, I'm John. Oh no, you can still sit. I guess for me, just make sure I'm in frame. I was a little skeptical of BII, to be honest, at first, but I trusted her and her research, and I think that's a big part of it as a husband, as someone who, you're like, this is a long-term thing. This isn't like a short-term relationship, And there's got to be a lot of trust in many ways in relationships. And so for me, it was just trusting in that her research was good, that she was doing the work and determining to the best of her ability what might be wrong with her. And there was a slew of things. And we had been through blood tests. We paid lots of money for alternative health, doctors. And we've seen lots of people and had lots of conversations, spent lots of time, lots of resources on this already. And so, I mean, when she discovered this and she came to me like so excited about it, I mean, for me personally, like there was really no other option other than to be supportive. Just, I get that some men have holdups with that though. I mean, as a man, like I get it. And I think a healthy level of respect and understanding on both sides goes a long way. So I can understand there might be some women who have not yet explanted who might be postponing and avoiding this conversation have with their husband because they might be afraid of how they would react. They might be afraid of things even beyond potentially an explant. And it's easy to kind of future-proof ourselves, future pace ourselves into this place of like, oh, he's not going to find me attractive. And there's a lot of things around, this whole thing. I personally stand firmly in the belief that you've got to stand in your own truth and do what's best for your own health, period. And I also believe that eventually, even if it's a little challenging in the beginning, a loving man should come around and support their wife and ultimately her health. So that's what it was for me. With Christina in particular, it's amazing, like the transformation that has occurred. Like I would have never guessed it would have happened. And for the first week, even after her surgery, she was like a changed person. And I was kind of thinking like maybe this is placebo a little bit, right? Because you got to kind of think about, well, if you believe wholeheartedly something is the cause of something, and then that cause is gone, or that something creating that cause is gone, well, there's naturally going to be some kind of a placebo effect. But it's been consistent these months afterwards. And so regardless of whether or not it was placebo, like who cares?
Yeah.
Like she was better. And I believe now that it wasn't. It absolutely was a result of her breast implants. If you look at research and you look at some of the stuff that these new studies. I mean, this is brand new stuff, and I'm not a doctor, and none of this is medical advice. But like if you look at some of the research and you look into like blood markers and some of the things that are coming out that show like there's a subset of people like in the world who have these blood markers that could show that or show that they have a naturally adverse reaction to foreign objects more so than others, right? So I don't know if I cited that right, or not even a citation, but just something that I noticed and picked up on. So there's that. And then, like, for men, I don't know if I know this group is one. Like, I'm not even allowed in this group, by the way.
Yeah, there's no men in the group.
Yeah, and which is I think really good. I think it needs to be a place for women only, and there needs to be that security and so on. But like if I were to share a message with other husbands, I would say support your woman wholeheartedly and her decision to explant. It is worth it. She is worth it. Her health is worth it. Your future together is worth it, and so much more. So,
wow.
Yeah.
Oh,
that's great.
It's like I'm not gonna cry at all during this thing. No, yeah, and I know I already wrote a blog about this whole thing because I do know that a lot of women are very scared to tell their husbands like, hey, I think this is why I'm sick, I want to get these removed, when their husband is like a boob man, right? Like they like their breasts and they can't imagine not having them around, and so they're very hesitant to bring this up to their husband, and they're honestly afraid that their husband's going to fall out of love with them or not be attracted to them anymore or not be sexually attracted to them anymore. I mean, it's a real thing. And I'm just the type of person, my health and my quality of life comes first, and you're either going to support me or you're not. And if you don't support me, and if my breasts are more important to you than like me and my health, then you're not the one for me. That's just honestly how I feel.
Yeah.
Like, that's just how it is. You know,
and that in and of itself is an attractive quality to me. And I would hope it'd be the same way around, you know. Sorry to interrupt you.
No, it's okay. You know, at the end of the day, it's just taking your power back, knowing in your gut what you know is right, doing what's best for you despite what anybody else might say or think about this situation. And I think it's really important, because I know a lot of women behind the scenes are doing their own research on breast implant illness and explanting and this and that, and they're not including their husband in on that. I think it's really important to show your husband what you're finding out and what other women are going through, and hey, this could possibly be what is wrong with me, and so on and so forth, and really bringing them into the mix. And they should be supportive, like, period. I don't know how else to put it. They should definitely be supportive of you and your health, and your breasts should not be priority or up there, you know. So yeah, that's it. And it's always great for as a medical provider to understand that side of that dynamic, because we see you guys in consultation and it's more focused on you, but there's so much more involved, and I think it's great to hear that side. So thanks for sharing that.
And just to give credit to Dr. Dev, I mean, I don't think there's ever been like a time where he's not. I mean, he's always, like, Christina's always first, but once she's done asking questions and he says, any other questions? She says, no, I don't think so. He looks at me and he asks me 5 questions. He asked me today, you know, how has it been for you? And so, I mean, obviously, if I'm involved in probably more so than most men would be, but like, not involved, but just here at these, follow-up appointments, and just, but just to give credit where credit's due, and hats off to you, Dr. Dev, for being, like, just acknowledging, you know, that is part of the process, and that's a big part of it, you know.
Appreciate that.
Yeah. As much as, you know, he's working on us and so on and so forth, like, there's a lot more behind the scenes and stuff that not only I have to deal with on my own, but, you know, as a couple, there's a lot of adjustments and new things, so, yeah.
Awesome.
Thank you.
Yeah, my
for
pleasure.
everything.
No, thank
you for your time today. Thank you for saving my life. That's literally how I feel.
It's a team effort, so we all did it together.
Yeah. Oh. Dr. Dev, you are a blessing. I saw a lot of things about Dr. Dev.
Trying to start a husband.
Oh. Yeah, that would be pretty. Facebook group for husbands, you know.
Thanks, Beth Ann.
Yeah. Cool. Oh, well, thank you, ladies, so much for just joining us and, you know, picking his brain. I know your question somebody else may have had or maybe didn't even think to ask, so we touched upon so many different things today. I appreciate your time.
Yeah, my
thank
pleasure.
you so much.
Yeah, there's a lot to it, so you're a great resource, and feel free to contact us and email us with questions, concerns. It's a difficult choice to make, so the best we can do is provide you our information in the most honest and wholehearted way we can, so you can make a decision.
Yeah, and it's aquaplasticsurgery.com, correct? Online?
Yes.
Yeah, so aquaplasticsurgery.com. You know, call any of the offices, Jupiter, Fort Lauderdale, Miami, schedule a consultation with Dr. Dev, and if somebody wants to get a hold of you personally for whatever reason, is there somewhere
I have an Instagram account. It's DRDEVVDO. It's kind of my personal one, so you can always send me a direct message there. Or if you want to email me, it's drdev@aquaplasticsurgery.com.
Can you say your Instagram again?
DRDEV, one more V.
One more V?
And then DO.
DO. So I'm going to put...
and Beatrice, too.
So I just put Dr. Dev's Instagram account in the comments, so you can definitely reach out to him there. And then Beatrice is, tell me yours.
Beatrice with a Z at aquaplasticsurgery.com.
Okay. Is that your face or your Instagram?
Yeah. No, Peace, Love, and Plastic Surgery.
Peace, Love, and plastic surgery. Cool, I love that. Cool. Boom. Yep, and then Beatrice is the one that handles the, you know, the scheduling and everything, so definitely get a hold of her, Dr. Dev, all that, and
Yeah, definitely. And I think Jennifer threw in one last question. Do you think there could be a relation to RH patients' body rejecting fluids such as implants? Yeah, I think there could be some correlation. Unfortunately, there's no concrete study to support that. Some of the things I've seen my patients do is they check some of their rheumatoid factors or some of their Hashimoto numbers that have gone down after the surgery. So, the next step I'm kind of looking forward to is talking to my patients' rheumatologists and their other doctors to see what they found post-explant, and that gives us an idea of which area to kind of focus our research on. So, all kind of growing things we're learning about.
Kathleen asks, what is RH? I was wondering that too.
Sorry, I didn't see it was I actually thought it was RA as in rheumatoid arthritis.
I think she's talking about aromatherapy.
Oh,
yeah.
Gotcha.
negative blood type.
Sorry, Jennifer. Not that I know of, but I haven't done. I haven't read anything about it. I haven't seen anything in the research studies about it, but definitely something I can look into in our journals and see if there's something on that. But yeah, thanks for that question.
Cool. And then Beatrice, you put a link in there.
I was trying to, yeah. I'm gonna do Dr. Dev's too, but it doesn't.
Alright, we're gonna wrap it up. I appreciate everybody so much, and then if you're watching the replay and you have a question, you can still feel free to ask it below, and then if I don't know the answer personally, I'll get with Dr. Dev, ask him, and then get back to you on that question. So, alright, thank you all so much.
Have a good night. Again. Yeah, thanks. It was fun.
Thank you.
Bye.